Welcome to Innovation in Diabetic Foot Ulcer Prevention and Treatment. Today, we will delve into the latest advancements and innovative approaches to managing diabetic foot ulcers. Diabetic foot ulcers are among the most challenging complications of diabetes, often leading to severe consequences like amputations if not effectively managed. As healthcare professionals, you are on the front lines of preventing and treating this serious complication of diabetes. Our goal for this event is to provide insights into the current challenges in diabetic foot ulcer management and introduce you to cutting edge techniques and technologies that are reshaping the future of diabetic foot ulcer care. The landscape of diabetic foot ulcer management is constantly evolving, with new technologies and treatment methodologies emerging that promise to improve patient outcomes. However, the challenges in this field remain significant, including the high prevalence of diabetic foot ulcers, the complexity of treatment, and the need for innovative solutions that can address these changes effectively. This event is an opportunity to delve into these issues and explore the future of diabetic foot ulcer prevention and treatment. Over the course of today's program, you will hear from leading experts who are at the forefront of diabetic foot ulcer research and clinical practice. We will begin by examining the current state of ulcer management and identifying the key challenges and barriers that healthcare providers face in delivering effective care. This will set the stage for our exploration of the latest innovations in the field, including advanced wound care techniques, emerging technologies, and new approaches to offloading, all of which have the potential to revolutionize how we prevent and treat diabetic foot ulcers. We hope that by the end of this event, you will have a comprehensive understanding of the latest developments in diabetic foot ulcer care and be inspired to incorporate these innovations into your practice. By embracing these new tools and strategies, you can help improve the quality of care for your patients and ultimately reduce the burden of diabetic foot ulcers. We thank you for your commitment to advancing the field of diabetic foot ulcer management and, of course, for joining us today. We hope that you find the presentations insightful, thought-provoking, and most importantly, applicable to your daily work. Welcome, everyone. Thank you again for tuning in. We're going to get started with our first speaker of today. So this segment will set the stage by exploring the current landscape of diabetic foot ulcers, ulcer management, including the prevalence of diabetic foot ulcers and the significant challenges faced by healthcare professionals in preventing and treating them. Dr. Maria Goddard here will provide insights into the systemic issues that complicate diabetic foot ulcer care and highlight the need for innovative solutions. We hope you all will gain a deeper understanding of these challenges and be motivated yourselves to seek out and implement new approaches in your clinical practice. So let's just dive right in. Thank you so much, Dr. Goddard, for being here today.
Thank you so much for having me. I'm really excited to talk about this.
Awesome. So let's just get started. So can you provide an overview of the current prevalence of diabetic foot complications and their impact on patient health as you're seeing it today?
Absolutely. It's really amazing that despite all of our advances in technology and disease insights, that the number of people who are being diagnosed with diabetes is increasing annually. The World Health Organization has looked into it, and it's anticipated that almost 800 million people will be diagnosed with diabetes by 2045. That's a really significant number. And we know right now that 6% of patients will develop a diabetic foot ulcer or foot wound. And so we really need to be paying attention to those people who have been diagnosed with diabetes, because this is a potential complication for a lot of them.
Wow, 800 million, that is a lot. So we talk about so many people that are being diagnosed with diabetes and that correlation between foot complications. So if we know that this is happening and it's an upward trend, what are some of those challenges in the prevention and treatment of diabetic foot complications? Like what's happening there? Where's maybe do you see the disconnect between the treatment and prevention for people living with diabetes?
I have noticed something really interesting as I have gone through my career. People rarely remove their shoes for a visit, whether that's their primary care visit, unless it is something that is targeted towards a foot exam. Even at home, people are wearing slippers or some type of footwear. And since neuropathy is a complication of diabetes, it can be a long time before people realize that they have a wound or an ulcer that they need to be concerned about. And so that delay in diagnosis can lead to some of the complications because we're already starting very late in the game. And so they can be complications of a deep-seated infection. Maybe the odor is what triggered someone to evaluate their foot. And so really trying to get more advancements in place that can do routine foot exams and foot care, and empowering the individuals who have been diagnosed with diabetes to examine themselves. We do it for breast exams. We should be using the same thought process for our patients who have diabetes.
So is it maybe common or less common for patients to really come to you or come to your colleagues when there's already a problem? So there's not a lot of time spent on the prevention because you're focused on the treatment. Would it be safe to say that there's that factor into play?
Absolutely. By the time they have gotten to me and many of my colleagues, there's already a problem that has been identified by another clinician or by the patient themselves.
So in talking about that, so how do some of these social and economic factors contribute to the challenges in managing diabetes related foot conditions? Like you mentioned, neuropathy, we're talking about diabetic foot ulcers. What are some of those social and economic factors that can really contribute to the challenge?
Well, we have finally started to realize and appreciate that the social determinants of health or non-medical factors play a significant role in individuals and how they're able to manage their disease. And diabetes is a multi-system disease, not just for the individual, but also the points it touches in the healthcare system. And so things like health literacy, there's really still a stigma associated with a diagnosis of diabetes. Our patients are often referred to as non-compliant, which is a word that I would like to go away. It's more about adherence because we don't know what those limitations are for them getting care. And so people are sometimes reluctant to talk about the concerns that they're seeing because they're worried about having another label attached to them. And so then we need to look at things like the economics of it. Do they have health insurance coverage? Does it cover routine exams? Medications. We've had some great advancements in medications and diagnostic tools, but for some of our patients, they're really realistically not available to them as yet. And so being able to address those social determinants of health and close that gap will go a long way for helping with the management of complications of diabetic foot ulcers.
That's very interesting. And we talk about it a little bit, you just talked about it from the patient side, but I would love to dig a little deeper into the clinical setting as well for healthcare professionals. What are some of the common barriers that you may notice that to that effective diabetic foot ulcer management, more so in the clinical settings?
Absolutely. Time, quite honestly, is a big factor. We're really limited in our encounters and have to be focused, but that's why this is really a great way to get that multidisciplinary team on board to help you with that. Um, I may not be able to have an in-depth conversation about optimizing nutrition and finding the correct foods, but a referral to an individual who's a dietitian or nutritionist can help with that. Um, if you have social management available, case management, who can help with things like getting supplies, because sometimes we will order something and not realize that it isn't available for that patient because of either their coverage limitations or where they're located, and also determining their support. Diabetes affects your eyesight. We talked about it affecting your nerves. And so they may not be able to perform a dressing change. So being able to identify if they have a support system in place, and if not, being able to help them with that, that may mean more visits to the clinic or having someone go to them. Really getting that multidisciplinary team on board can really help with dealing with the time factor.
That's a very interesting. Time. It's what we hear about a lot. Time is limited, and you can't get it back. So that is definitely something that we've heard before. So, you mentioned it a little bit with the multidisciplinary team, but how can health professionals better address some of the challenges that you mentioned to really improve patient outcome? Are there things that you think that your colleagues can also do or implement in their own clinical settings to help them address these challenges?
Yes, I think that one thing that would be really helpful is a basic foot exam and teaching the patient or their caregiver how to do that as well, so that we can identify things sooner. Evaluating, it may not be that they can notice something on their foot, but maybe they'll notice that the wear pattern on their shoes is starting to be different, or a friend or loved one way talk about the way that they're walking and their gait changing. And so, really using those clinical visits to educate the patient for ways that they can identify changes, that can help as well.
Awesome. And you mentioned briefly the caregiver. What do you believe is the role of the caregiver in treatment of these diabetic related complications, foot
So it's
complications?
a really delicate balance because I always tell caregivers that I don't want them to become the good cop, bad cop. So they're the ones who are insisting that they take their blood sugars all the time, that they eat the correct foods. We really want them to be a partner and the advocate and the voice for the patient. And so asking how they can help if they feel comfortable doing certain things. They might not feel comfortable doing a dressing change, but they might feel comfortable watching a video and maybe helping the patient through that. And so really getting that team together, the most important member of that team is the patient and their caregiver, quite frankly.
Thank you so much. And then going back to the healthcare professionals, are there any resources or things that you believe would be helpful as healthcare professionals try to better inform themselves and find ways, or are there resources that they themselves can give out to their patients to help educate together? So, are there any resources that you may think of or that you commonly use when you're trying to educate others?
Yes. In my care setting, I don't have a case management or social worker available. And so I go to the website gethelp.org, which is really helpful. You can put the patient's zip code in, and that can help them get access to resources for medical care, dental care, um, eye care, food support. That's a really great resource as well. And then the other resource that I would recommend is the American Medical Association came out with a document on how to communicate with patients and how to close that gap of health literacy in the way that we address patients instead of saying diabetics, people with diabetes, and just really helping to richen that patient clinician encounter. And that's another free resource that's available for download on the American Medical Association website.
Thank you so much. You've given us so much to think about, including the growing prevalence of people being diagnosed with diabetes, which are going to unfortunately lead to some of these foot health complications. We talked a little bit about the social economic factors and the common barriers and challenges. So, with all of that, I want to know my last question here is there anything else important that you would want the audience to know as they are continuing to educate themselves about the prevalence of these diabetic foot ulcers and the problems that that poses for people living with diabetes? What would you like the audience to know?
That the severity of a diabetic foot ulcer can change very quickly. And just get help as quickly as you can. If you feel that it's something that you cannot manage, referral to a higher level of care as soon as possible. Because the major complication that we worry about is infection, which can lead to amputation. And we know that the morbidity and mortality after an amputation is very high, on the level of 30% within 5 years. And so we want to make sure that we are taking care of these wounds and these ulcers while they're small and manageable before we progress towards amputations.
Thank you so much for taking the time to walk us through that, and really appreciate you again, Dr. Goddard, for just being willing to talk to us today. I really appreciate it.
Thank you so much.
Welcome back, everyone. In this segment, we are joined by Brenda Freemuller, the Assistant Vice President of Wound and Hyperbaric Shared Services at Intermountain Health, to explore crucial questions about diabetic foot ulcer prevention. Brenda brings a wealth of expertise in wound care, and today she'll be sharing insights on whether diabetic foot ulcers are preventable, what people living with diabetes need to know to avoid them, and who is most at risk. We'll also discuss early warning signs that both patients and providers should be aware of, along with the latest techniques and technologies that can help detect diabetic foot ulcers before they progress. As healthcare professionals, many of you know that preventing diabetic foot ulcers can make a significant difference in patient outcomes. Brenda will provide actionable tips for educating patients, as well as effective approaches for early detection and preventative care. This conversation is aimed at equipping you with practical strategies to enhance diabetic foot ulcer prevention efforts and ultimately improve quality of life for those at risk. So let's get started. So hopping into our first question, I just wanted to ask, are diabetic foot ulcers preventable?
Yes, diabetic foot ulcers can be preventable. The biggest part of that is early and good management of blood sugar levels, making sure that your hemoglobin A1C is in a good range, and really working with your primary care, your dietitian, all of those people that are out there to help you support the management of your diabetes. Over time, high blood sugar levels will have effects on the nervous system, which affects your ability to feel your feet. Also, it can break down the calcium in your bones and make your bones more brittle. So making sure that your blood sugar levels are in a good range, and then maintaining a healthy weight is really important. The less pressure you can put on your feet, the better that they'll hold up for you over your lifetime. Daily foot inspections are also very crucial in preventing foot ulcers. Being able to see those things before they become a big problem can really save a lot of issues down the road. Proper footwear and avoiding walking barefoot is also really crucial to helping avoid injuries. And we'll talk more about some prevention things as we move along.
Thank you so much. So I guess my next question is, who is at risk for developing foot ulcers? And what are some of those early warning signs that patients need to be aware of, that maybe they need to go to their doctor if they see
Right,
that?
sure. So anybody with diabetes, whether it's type 1 or type 2, over time will have these issues that happen just from the high blood sugar effects, like I said earlier, on the nervous system, on the bones, on the circulation. So especially people with neuropathy and then what's called peripheral artery disease, or basically poor blood circulation, are really at high risk for developing foot ulcers. What tends to happen with some of those people is that the bones start to break down, the foot structure changes, and then you walk differently. You're putting pressure on parts of your foot that weren't intended to have pressure on them. So really anybody with diabetes will be at risk. And sometimes neuropathy isn't always, and peripheral artery disease, those are things that creep up over time. They aren't something that you just wake up with one day. So definitely just being aware of your body and knowing when those things, maybe you start feeling some changes with pain or loss of hair on your feet and your legs. Just some general changes to things are definitely something to bring up to your provider.
Thank you. So knowing all the folks that are at risk, and it seems like there's a big population of folks, those with diabetes, but you mentioned both type 1 and type 2. I want to definitely make sure that people are aware that both of those populations of folks are at risk for developing foot ulcers, because that's a really important note to draw out. But so such a big population of people that are at risk. So what tips or tricks would you be able to share with patients about avoiding diabetic foot ulcers altogether before they even get there? So what tips or tricks are there?
Okay, sure. So besides the things that we talked about earlier, just avoiding them by trying to keep your sugars under control, is that people that have diabetes should be practicing good daily foot care. And that includes washing and inspecting your feet, looking for any calluses, sores, cuts, blisters, or redness. Especially focus on areas where calluses are starting in between the toes. Those are areas that people don't think of as being maybe as serious, but a lot of foot ulcers go unnoticed because they're hiding under those calluses, or they present between the toes where it might be a little bit more difficult to see. I've seen a lot of patients that come in and they've got these horrible calluses, and they're like, well, there's no wound there, it's a callus. And then as soon as we start cleaning the callus up, we find a big wound underneath. Basically, those calluses act like rocks in your shoes. And when you can't feel that rock in your shoe because of the neuropathy, it creates that problem of like you basically have your own rock in your shoe and you keep walking on it. And under that callus, it's wearing away at the tissue and getting down into the bone and can lead to infection and all kinds of other issues for you. And also, it's really important to wear well-fitting shoes and moisture-wicking socks. Avoid walking barefoot, even in your house, unless your house is like pristine, which I know mine is not, and you might have kids or grandkids or pets. Things end up on the floor. And if you're walking around barefoot, you know, you can step on something as small as a Lego. I've seen people come in with stick pins in their feet. You know, those are the kinds of things that may go unnoticed, and they happen because you're walking barefoot, and you don't feel those. So even in the home, it's important to wear good shoes. And then, especially if you have neuropathy, it's crucial to purchase your shoes from a source that will measure your foot and check to make sure that the shoes fit the best. The reason for this is that people with neuropathy, they tend to buy shoes that are too small because they can't feel their feet. And so they'll buy shoes that are too small because then they finally get them tight enough that they feel like there's something on their foot. And then what you're creating is you're creating pressure points because you're squeezing your foot into something that's too small. And just that can, I've seen people that have come in that's the problem. And they're like, no, that shoe fits. And if I trace their foot and put the shoe on it, it's pretty clear that their foot does not fit in that shoe. But they've been forcing their foot into it. So just really important to look for places that still measure. Or if you need to go to a specialty store, there's orthotists are good resources to help find the right shoes or the right insoles to meet the needs of your foot. Another important thing is to look inside your shoes before you put them on. Not only walking around barefoot in your home is with the hazards, is that things can end up in your shoes, especially if you have, like I said, pets or grandkids or kids. Things can end up in there. I had a gentleman one time who we couldn't figure out why his foot was breaking down. And when we took his shoe off and looked in it, his dog had dropped a tennis ball in it and it had gone to the front of the shoe and he didn't know it was there. So it's so important, especially with neuropathy, before you put on your shoes, take a good look inside those shoes to make sure that there isn't anything in there that could be potentially causing a wound on your foot.
Wow.
Another great, oh, sorry.
No,
Another
she's
great thing is look for a podiatrist that specializes in the care of the diabetic foot. Regular visits and assessments for callus removal, toenail clipping, and those kinds of things can help prevent a lot of future issues for your feet if you do a good maintenance program. And podiatrists that specialize in this are also great for helping you find the right shoes and insoles that can help adjust for any changes in your walking pattern. Like I said earlier, when the bones break down and some different things change with the foot, people start walking differently when they have neuropathy. So you tend to shuffle more. You don't step the same way that you normally would. And these specialists are really great at helping you find the right footwear or making the right changes that might be needed to help with that. They can also help correct any foot deformities that might be occurring because of the changes in your diabetes. We see people with hammer toes and, you know, bunions, bunionettes, you start having toes that cross over, those kinds of things. That's other things that they could, you know, potentially help you with to keep your feet in the best shape so that they hold up for your lifetime.
Thank you. That's so helpful. And we talked about what patients can do to, or people living with diabetes or prediabetes can do to avoid these diabetic foot ulcers. But I would like to ask you on the flip side, as a healthcare provider, are there techniques and new technologies or old technologies altogether that can help, that help and can help you and your colleagues detect these ulcers sooner before they become more severe?
Right, right. So, regular visits with your primary care doctor is so important. Not only do they help you manage your medications, but also, part of their the work that they do, at least on an annual basis, is to help do some foot evaluations and check you for neuropathy and check you for potential problems to try to get you to the right place. So there's a lot of, like I said, like you said, like older techniques that we use with monofilament testing. Um, some places, I think some people still use tuning forks, because if the patient can feel the tuning fork on their foot, that kind of helps sense whether or not they're losing sensation. The monofilament tests are good for just it's a little bendable filament that can be pushed onto the bottom of the foot, or even the top of the foot, just to see what people are feeling and try to help gauge whether they're losing that protective sensation, to know when they might be getting into trouble with their feet, that they might be having pain. So those are some old things that I think are still good. They're still easy and expensive out of the pocket. But we are seeing some improvements in technology. There's a couple products out there. There's socks that'll help detect temperature changes. There's also mats that you can stand on once a day, that can detect different temperature changes that might be indicative, or might be indicating that there's something happening in the foot that we can't see yet, that needs to be addressed. And these kinds of things are connected, through cellular networks, so they don't even require like smartphones and Wi-Fi. But it sends messages, it sends reports over to the company, where they have nurses that are monitoring these things, and they can help watch for any changes and then reach out to the patient and just say, check in. How are things going on? Can we look at you? Is there somebody who can look at your feet? Can you look at your feet? Has there been a change in your walking pattern lately? Did you go on a trip? Did you get new shoes? Is there something going on? Can you sit and put less pressure on your feet more during the day? What kinds of things can they kind of help troubleshoot on that? And so their goal is to try to keep you from going to the doctor if they can, because if they can pick up on these things early and help the patient do some interventions, then that means less calling and maybe coming to the physician. But when the physician does need to know, they will escalate that information to the physician to see, does the patient need to come in? What were the scans? What did they look like? Is there something going on that I should be aware of? So it's great. It's a great resource. I know initially I had some physicians that were concerned that they would get calls all the time, but the beauty of the program is that it's designed to not have that happen unless there's really a need to come in. The facilities that I work at uses one of these technologies with some of our patients, and we've had some really great success stories of people that had something that showed up on the scan, and they maybe didn't have an appointment scheduled, and they scheduled something, and the physician has been so grateful because they were able to catch something before it got much worse. Because the whole idea is, yes, maybe you still do develop a few smaller wounds, or you have something that's starting. Let's get on it then, and not wait for it to get to where there's blood in the sock, or there's redness, or there's swelling, or all of those things that indicate that now we've got an infection we need to deal with. So we've had some great success with these, with patients that it works, with some of the patients it works well for. There's also some devices out there that kind of can help the primary provider, detect if neuropathy is starting and the extent of that, to try to gauge along with some of those other things that are happening out in the visit with that patient to try to help identify patients that might be losing protective sensation and just don't realize that they're losing protective sensation. So you can start some interventions with those patients as well.
Wow, that is amazing. And I think something that we talk about at the Amputation Prevention Alliance a lot is what is possible, the realm of possibility. And I think as you're talking about these new technologies and the things that are evolving, it just seems like the realm of what is possible to help keep people safe and the quality of life improving. And it seems like there's just so much out there. So I appreciate you spending your time to talk to us today and giving us a lot of information. And I guess my final question for you is just if you have any final thoughts, is there anything else that you think that either people with living with diabetes or pre-diabetes, those who may be at risk for developing these foot ulcers should know? And on the flip side, if there is something that you want to say to your fellow colleagues as healthcare professionals, if there's something that they should know. Any final thoughts?
Yeah, I think really just reiterating that that the patient yourself has a lot of power in this. And I know that choices are hard. It's hard when you're told you have diabetes and now there's things that you maybe love to eat before that you need to avoid or you can't eat. And but it's when I think about the long term, and it's always hard to think out that far, is really there's a lot you can do to help yourself. There's a lot we can do as healthcare providers to try to help, but a lot of it comes on to the person themselves and being able to make some of those changes that need to happen. There's a lot of resources out there I think we forget about, and just really I encourage, and I know we kind of talk about both the providers and the patients in this, but really for the person living with diabetes, take the information from these education offerings that you guys are providing here, and next time you go to your doctor's office, have that list of questions to ask them and really empower yourself to try to get the answers that you need and to make sure that maybe some of these things that are out there that they might not be aware of are something that you could use to help make your life better.
Thank you again so much for joining us, and we really appreciate you spending your time with us today.
Yeah, thank you.
Thank you all again for joining us today. We're going to move on to the next segment. In this segment, we will spotlight the cutting-edge advancements in emerging technologies that are revolutionizing the prevention and treatment of diabetic foot ulcers. Dr. Freiberg will discuss the latest developments in advanced wound care techniques and other innovations that are shaping the future of diabetic foot ulcer management. We hope the audience will take away and learn about some of these most promising new developments in the field and be inspired to integrate these innovations into their own practices to ultimately improve patient outcomes. So Dr. Freiberg, thank you so much for being here today. And I would just love to jump right into the questions.
Okay, Jakara, thank you very much. It's really a pleasure to be here on a very important topic. You know, I've been involved in diabetic foot care for well over 40 years now, and I've seen a lot of great changes. You know, when I started, we just had gauze dressings and maybe saline or povidone iodine, and then 25 years later, we started to see advanced therapies come in like Regranix, bicalpurmin gel, and then the skin substitutes came in, bilayered and single-layered skin substitutes, cellular products, acellular products, and then so many other advanced therapies have come on the market. And certainly the last 20 years has been an explosion of advanced therapies, which can sometimes get rather confusing for practitioners that aren't living with this day in and day out. It's also very exciting and very interesting. Many of us do diabetic foot ulcer and wound care research to keep abreast of all the latest and greatest new advanced therapies. So your question really evolves around, what do I think is so new? What do I think is so great? And I can honestly say, my perspective is the same as so many others. But in my travels globally and meeting with people overseas who don't have all the products that we have here available to us in the United States, I get a sense for what they think is really exciting, as well as what excites me. So if we look at, let's say, the last international working group of the diabetic foot held in Netherlands in 2023, which happens every 4 years, we kind of get a sense for what's been the most exciting new things that have come about. And as far as wound care goes, one of the things that's close to my heart and that I've researched is topical oxygen therapy, which is really interesting because it's not new. That's what most people don't realize. The first paper was published in 1969 by Fisher in The Lancet. And it was often discredited as not possibly being able to work, certainly from Leslie's 1988 studies out of Rancho Los Amigos Hospital that said it can't work. We did a study 14 days and we found no difference in healing between the control group and the active group. And that kind of put a nail in the coffin until you look at that study that was so horribly flawed and published in Diabetes Care. I will say it would never be published now, but it was only 14 days. So despite that, topical oxygen has continued on, plugging along and doing better and better and better research. And getting back to the International Working Group in 2023, it was highlighted, the study that promoted one of the topical oxygen units, the TWO2 therapy, cyclically pressured oxygen. It was highlighted from a Diabetes Care article as being one of the best new articles in the last 4 years for an advanced therapy, which is pretty incredible because after all the years of being considered not possibly effective and questionable, it certainly has a good body of evidence behind it. And to that point, there have been 4, 5, 6, 7 worldwide systematic reviews all saying the same thing, that in the proper circumstances, topical oxygen is a great adjunctive therapy for non-healing or chronic diabetic foot ulcers. So that's been pretty exciting over the last couple of years, and it's changed everybody's thoughts and opinions just since, let's say, 2018, 2019. So that's pretty new. Obviously, everyone's aware also of placental membranes as being such a big boon for our wound care practices, although it's recently come under attack for overutilization, like so many things. But so many papers and studies have shown the beneficial effects of applying placental membranes, amniotic tissues, amnion chorion tissues to chronically stalled wounds, especially diabetic foot ulcers, and how these products can expedite healing. So that's not quite new because placental membranes and those tissues have been in the medical marketplace, I think starting back in the early 1900s. It's just that now they're commercially produced and anybody can get these products anytime that they want them. There's about 200 companies selling these. So these are new advancements, certainly over the last 10, 15 years. But then you should ask the question, well, what excites you, and how do you get excited? Or what's new and innovative? And if I really think about it, I got really excited when I saw fish skin come on the market. This had to be 6, 7 years ago. Fish skin from Iceland, codfish, omega-3 wound matrix, I think it's called. And I liked it because it had the same structure as pretty much the same structure as human dermis. It facilitated great ingrowth of new blood vessels, new tissue regeneration. And I had great experience with this. So we're going back probably 6, 8 years ago when I first started using that. And it's become very, very popular new modality because it's off the shelf, has a long shelf life. You don't have to unfreeze it. You don't have to prepare it any particular way. There's many different versions of it. So we were able to use this fish skin in the operating room for skin graft donor sites. So we were able to use it for chronic wounds, venous leg ulcers, wound dehiscences, etc. So it's been really popular. It's gained a lot of popularity, I should say, since I first started using it when it first came on the market. And now there have been a number several good and large clinical trials that certainly support its use. That's another important point to say. There are so many products on the market without much rigorous research, I should say, or clinical trials, comparative clinical trials, that I always recommend that people consider using the ones that have proven efficacy based on published randomized controlled trials. And, you know, we recognize that controlled trials have a very tightly controlled environment, if you will, and it's not the same as real world evidence. But the real world evidence almost always supports what was shown in the clinical trial, just in a much broader utilization. So it's been good. And that's been the same for topical oxygen. It's been the same for the placental membrane products, and certainly for the for products like the fish skin that we're talking about. And doing a lot of clinical trials, we kind of get excited about synthetic products, acellular products, cellular products from pigs, porcine products, bovine products. We have sheep foreskin products. So there are a lot of new xenografts that we have available to us aside from the human allograft. So it gets very, very exciting nowadays. Then we can turn our attention to synthetic products. There's a lot of new synthetic products on the market. And quite frankly, I can't keep track of them all, but they're nanofiber products. A bioactive glass product is a very interesting product that we have also trialed ourselves. So it's an exciting time to be in wound care. I think I should say one more product that really intrigued me, because traveling around the world, I know in different cultures, there's different cultural taboos, if you will, or you can't use this type of product or that product. So I've always been interested in the autologous products as well. Autologous blood clot, autologous fibrin leukocyte patch. Certainly, these all have clinical trials supporting their efficacy as well. So you're using a patient's own blood, spinning it down and applying it in some fashion to their chronic wound, and that can help expedite healing. We also have the older version with platelet-rich plasma that I had trialed years ago, but now it's becoming useful again because it comes in different types of applications with now little discs or membranes that can be applied. After you spin it down, it comes into the form of a membrane that you can apply on a wound, and it's not so messy to use. So there are many, many things, and sometimes it's hard to decide, do I use this or do I use that? The big limiting factor is always coverage by CMS, always commercial carriers. Now, I had practiced in the VA system for a long time, so I didn't have to worry about those hurdles because we had almost anything that was FDA approved. If they had the proper licensing within the VA, I could use it. So I got to trial many things that most people in the commercial world don't have the opportunity to because they can't get paid for it. So that is a big stumbling block. Many of the newer products do not currently have CMS coding to allow for them to be used. So they're more or less used in the federal service or on Medicaid plans in various states or what have you. So it's just an important point to keep in mind. And I'm certainly no coding expert, not at all. Because I was in the VA, I didn't have to worry about that since my years in private practice. But CMS coding is a very, very important hurdle that many of these products have to overcome to gain widespread use in the commercial market. And many of them have. Some are still finding that challenging, however.
And I think, thank you for that. And certainly a lot to keep straight. And I appreciate you for going through a lot of the new advancements. And you kind of went a little bit with the CMS coding into one of my other questions, which was, how can healthcare providers integrate some of these new techniques and technologies into their own practices, and what are some of those hurdles? So you mentioned CMS coding, but are there any other ways that you think that any other barriers or opportunities for healthcare providers to integrate these techniques?
Well, luckily, many of these companies, even if they do not have CMS coverage, and CMS coverage is usually a predicate for getting commercial insurance coverage. But many of these companies are looking to expand their visibility, let's say, in the marketplace, and they will often trial some of these products. Like there are, I'll use my topical oxygen example, since that's one that is actively seeking a CMS approval. If people are not in the federal services, DOD, Indian Health Services, or the VA, they can't use these on a regular basis, but many times they can get trials or opportunities from the companies to use these. Otherwise, patients can pay for them themselves, depending on the cost and how much the treatment is. For instance, overseas, many of these products are not available, but people still want them and use them, so they will just have to pay out of pocket. But the CMS reimbursement is a big hurdle that I'm happy to say is probably going to be overcome, because the problem is such a great magnitude that they have to address this, with millions of people having foot ulcers just in America alone, not counting all the other chronic wounds. So there are many opportunities to trial these things. Many people engage in clinical trials in their own clinics. It's a great way. That's how I found out about many of the products. I was always interested in trying something new. Many training programs also have the opportunity to use these products. Many private clinics have the opportunity to do clinical trials sponsored by these companies. And that's a great way as well. I guess we can mention also the Diabetic Foot Consortium, which is an NIDDK, NIH initiative that's looking to study more and more different types of agents and looking for biomarkers currently. But I'm sure eventually this is going to be expanding into formal research into new and upcoming different types of treatments down the road, with a standardized clinical trial master protocol, as it's called. So it is tough, but there are options available for advanced wound care therapies. We mentioned placental membranes, autologous blood clot treatments are available. I'm not quite sure if the fish skin is, or some of the other ones aren't, but I recommend that people just seek out the representatives of these companies and see if they have a difficult patient, if they can get a free trial. And many of these companies are very generous in that regard, and they will do it. So there are many opportunities as well as roadblocks that we see, but I think those are going to change down the road.
And I want to bring it back to the patient for a second. You talked a lot about a lot of the techniques that are out here, the treatments that are evolving, and you mentioned you have over 40 years of experience. I would love to know, compared to the traditional methods of treating diabetic foot ulcers that maybe you used in the beginning of your career, versus compared to the more advanced wound care techniques that you're seeing now, what has that meant for the patient themselves, whether that's your ability of the patient comfort, or your ability to follow up with patients, or reporting, or things of that nature? Has anything changed in terms of being able to manage patient outcomes and safety and comfort with these new advanced therapies?
Well, I think it deserves mentioning that all these wonderful advanced therapies that are coming down the market will do nothing if you don't pay attention to the basic tenets of diabetic foot ulcer care. I know Dr. Armstrong will be talking about offloading. That's absolutely key. And trials, multi-million-dollar trials have failed because they didn't pay proper attention to offloading. And that's a very basic debridement, assessment for perfusion, arterial perfusion, nutrition, looking for underlying infection, looking for osteomyelitis. None of these age-old standards of care can be violated. They always must be followed. And then if your patients are not making progress, let's say over the 4 weeks of good optimal standard of care, then we start thinking of ways that we can expedite healing or give them a special boost, if you will. And that's when we'd start using the advanced products. We didn't have advanced products even really back in the 80s that I can recall. So we had to rely on good standard of care. And I will say, as I'm sure Dr. Armstrong will talk about, total contact cast has made a big difference. It's much more popular now than it was even when I trained back in Boston, but yet it was first introduced, I think the first report was in 1928 out of India, and then it was popularized by Paul Brand in the 60s. So again, it's paying attention to offloading and proper care. And then we can give more opportunities for sicker patients for the advanced therapies. The ones who need these advanced therapies the most are the very patients that are not included in the trials. Patients with renal failure, on hemodialysis, or with modest levels of ischemia are usually excluded from undergoing these trials. Those are the very people that need the trials, because those are the ones most in need of advanced therapies. There also have not been a lot of comparative trials of one advanced therapies to another. But I just see the opportunities growing and growing and growing as this marketplace continues to evolve. But if I can, and it goes back to the patient themselves, which, our care has to be patient-centric, we need to focus much more on prevention. There have been so many wonderful trials on advanced therapies, but how many trials have there been in the last 20, 30 years on prevention? We've had some footwear trials or footwear studies back in the 90s, but since the 20s, I can't recall a lot, maybe a few on prevention measures. And prevention also includes remote patient monitoring. I know, we mentioned home care for the patient, so patients can have an active participation in their own care with smart mats or smart socks, or monitoring skin moisture, monitoring skin temperatures, and remote patient monitoring that actually can be paid for by commercial carriers. And I know you wanted to talk to me about telemedicine too, and this is where that can come in, especially patients living in the rural areas. They can't get to see a doctor in a city clinic every single week, which is our custom generally. So if we can use remote patient monitoring and telemedicine, then we've done a much better job on following these patients carefully between visits, because everyone who treats these high-risk patients know they can be great one day and 2 days later they can be falling apart. That's why you don't like to let them go for 2 weeks without seeing them. So telemedicine is wonderful. It's finally being paid for. Remote patient monitoring is being paid for. Not great, but it's still an advantage to be more specific towards the needs of the patient. And without prevention and without good prevention protocols, we're never going to get a handle on the tsunami of diabetic foot ulcers that's coming down the road. And remember, diabetic foot ulcers are the leading precursor to amputation. It's the greatest risk factor for amputation. And our whole job is to prevent amputation. And the best way to do that is to catch that ulcer early, or if we cannot catch it early, even prevent it. And obviously, primary or secondary prevention is always the best way to do it. But we need to focus far more on prevention and more investigations on excellent prevention measures, protocols, combination protocols, combinations of therapies. There's a few trials going on around the world. There's one a friend in Australia who's looking into a comprehensive prevention protocol as well for his indigenous patient population. So I needed to say that because I don't see us effectively stemming the tide of DFUs and subsequent amputations unless we focus far more intently on prevention. And that's the whole name of the game, right? This is the Amputation Prevention Alliance. And unless we do that with home measures like home foot inspection, I mean, there's new technologies, but nothing new. In 2008, we published an ADA paper on consensus on foot examination for the intention of telling non-specialists, this is what you need to look for. These are potential risk factors, and you need to intervene early and get that referral early. The ADA publishes standards of medical care for diabetes every year, and there's always chapter 12 or section 12 is on foot care as one of them. And we're focusing more on evidence-based therapies, but we've also said there also needs to be more of a focus on prevention and thorough evaluation of the diabetic patient in their entire lower extremities so that we can catch problems early. If you catch problems early, you can intervene aggressively and prevent far more serious problems. So we really need to be paying far more attention to formalized prevention protocols.
Thank you so much for that. And for our audience who may not have had a chance to tune into our first part of this series, we do spend a good time talking about prevention and the early signs and symptoms. So we would encourage you to go back and watch that if you have not. But I appreciate that. It's always important to keep that in mind. So I have one final question for you. And the question is, what does the future look like? Can you discuss any emerging technologies that show promise in prevention or treatment of these diabetic foot ulcers? What does the future look like?
Well, I think the future for diabetic foot ulcer patients is bright. We're never going to stem that tsunami. We're not going to stop it. It's going to happen with all the migration into our countries from third world with higher rates of diabetes, as has already been discussed. But with all the new technologies, with the great interest in new advanced therapies, as I've said, I think the future is bright. Once CMS covers more of the advanced therapies that we've talked about as clinical trials progress, and there's a lot of interest in clinical trials for diabetic foot ulcers. And once the data is there, then we'll see CMS coverage, and then all these advanced therapies will be readily available to the population at large. We talk about prevention. We know we have the smart mat that's widely available now. We have smart socks. We have temperature assessment, thermography. There's a skin moisture index, skin moisture assessments, transepidermal water loss assessments. There's so many things that have not made it into mainstream practice. But I think once the clinicians taking care of these diabetic patients, and that body of clinicians is growing, of course, then I think these new modalities will become far more common in clinical practice. And I have to say that clinicians, doctors, nurses, PAs, NPs who care for these patients need to follow the international guidelines. They just need to follow them because they're updated every year based on good, strong clinical evidence, and pay attention to what's happening overseas, because many of the things overseas may come into our country. But you need to follow the guidelines because the guidelines are always being updated into new advancements for wound healing. Talking about new simple operations like a flexor tenotomy, the latest, greatest thing that was promoted in the last international working group for toe tip ulcers, if it's a flexible toe tip. Well, all of a sudden, that's taken the diabetic foot community by storm. And many of us who've been doing these procedures for 30 years scratch our heads and say, what's new about that? But it's becoming aware. It's really awareness that makes a difference. And by following guidelines, following the literature, more and more clinicians become aware of current therapeutics, current modalities for treating patients, and the need for proper and thorough assessment. So I think the future is very, very bright. A lot of new things will be coming down the pike as we move on from year to year, but we can never pay attention. We can never forget to pay attention to the basics of care that we've already said, and we can never pay attention enough to the need for aggressive prevention protocols. And I think we'll see far more interest in prevention in the years to come, because we have to. We just have to.
I couldn't say it better myself. Thank you so much, Dr. Freiberg, for taking the time to really walk us through the advancements, talk more to us about how we can work better and work smarter, actually, for the benefit and the good of all of the patients who really deserve this. So really do appreciate you taking the time, and thank you so much.
Okay, it was a pleasure. Thank you, and goodbye, everybody. Thank you for being with us. Thank you.
All right, welcome back. We have a great another segment for you on offloading diabetic foot ulcers. So this segment will focus on the critical role of offloading in the treatment of diabetic foot ulcers, a practice that involves redistributing pressure away from the ulcerated area to promote healing. So Dr. Armstrong here will share success stories, discuss the latest trends, and explore the future of offloading techniques. So we hope the audience will come away with a thorough understanding of how to implement these effective offloading strategies in their own practice, leading to better healing outcomes for patients with diabetic foot ulcers. So thank you so much for joining us here today, Dr. Armstrong. Really appreciate it.
Ethan, thank you so much. And thanks, by the way, for letting me play hooky from a crazy clinic where I was just practicing what we collectively are going to be preaching. So here we go.
Well, what better time to get started? So I guess with further ado, let's just jump right into the questions. So
Yes, ma'am.
the first question that I have is, can you explain the concept of offloading in the treatment of diabetic foot ulcers, and why is it important?
Yeah, sure. And again, this is one of these things that's easy to explain on a Zoom or on a recording, and it's a little harder to do in real life. But just because it's hard doesn't mean it's not kind of fun and rewarding. And so, but again, we often say that it's not what you put on these wounds that heals them, although we have a lot of things that can accelerate healing. But really, more importantly, it's what you take off. And if you take off what's not viable, and that's called debridement, or if you're French, debridement. And if you take off the pressure, or as you said, Chikara, if you redistribute pressure over a larger unit area, then in the face of good blood flow and absent infection, the majority of these wounds are going to heal and hopefully heal predictably. The trouble is it's actually really hard to do, and it's not done as well as we could, me included. And this has been an entire career for me. So what offloading refers to is not offloading responsibility; it's offloading pressure, and it's increasing the unit area so you reduce the overarching pressure. We could through all kinds of different things, through casting, through different kinds of boots, through different kinds of orthoses and things of that nature. And we're going to be specifically talking about offloading diabetic foot ulcers now, but we can easily also talk about offloading feet before they get an ulcer or even afterward too.
Awesome. And you mentioned that it can be a little tricky, or there's challenges in offloading, but can you talk about some of the most successful case studies that you've seen recently in the application of these offloading techniques?
Yeah, I mean, I'll just tell you about quite literally the last, and this is a guy, I've had 2 patients already that they're working on early this morning here at Keck at USC, so let me just explain. It's, again, this is easy to talk about, and it's hard to explain unless you're actually with the patient. But one of my mentors used to say that pain is a gift. It's a gift that no one wants. And these folks with diabetes, it's just so silent and sinister. They get silent heart attacks, but they can also get a silent foot attack where they literally can wear a hole in their foot, like you or I might wear a hole in a stocking or a shoe, right? And that's the diabetic foot ulcer. And they don't have any painful feedback. And so when we're trying to offload the foot, we might want to put them into a cast or a boot. But if we were doing that to ourselves and we didn't have any pain or any symptoms, we probably wouldn't want to. We'd probably rail against it. And that was the gentleman that I just did now. He's probably just getting discharged from the clinic right now. But this guy is just the sweetest guy in the world. He actually works and now owns, he worked for and now owns a landscaping company. And he was furious when he came in with a wound. And I told him that that it would be best if he were to offload this foot and this wound ideally so that he wouldn't get an infection and end up losing his leg. And he didn't quite understand that until we started doing stuff together. So I said to him, look, let's just try wearing this irremovable boot for a week. And pardon me, this wasn't a boot. In his case, it was a cast. It was called a total contact cast. And he didn't understand why he had to wear a cast. But I explained to him, look, you have to wear this cast because we have to redistribute the pressure. And if you had a broken ankle, you wouldn't think twice about wearing this cast, right? And he said, of course not, Dr. Armstrong. In fact, I had a broken ankle with you a couple of years ago. And I said, you were in a cast, right? He said, yes. I said, what's more limb threatening, a wide open wound or a broken ankle? And he said, oh, I think I kind of understand this a little bit now. So he wore it the first week. And then he came back and and then I took a picture of the wound and I measured it for him and he looked at it. I looked at it. His son who brought him up from San Diego looked at it. I then brought him back the next week and then the next week. And he then had like a series of photos. And this guy now comes into me and shows me these photos. This is like 15 minutes ago, just like you or I'd be showing someone our kids' pictures. He's showing the picture of this wound healing. And so he really took pride in it. And it's about, look, this is no different than anything else we do in surgery and medicine, and where we want to do something with our patients and not to them. And that's the big idea. And when you're doing that, then that's your patient for life, right? You are literally and figuratively married to them. And it's the best kind of marriage, even though it can be frustrating, ultimately rewarding.
That's awesome. And you mentioned, there are these successful case studies that you've seen, that you've witnessed in your own patients. But also there can be challenges. So what challenges do patients and clinicians face when you're implementing these offloading strategies effectively? What challenge?
So the hardest thing is incorporating this into someone's real life. If it's on their right foot and they have to drive, if they are maybe older and with a little more frail, and this might increase instability, and they might fear, a fall risk, and this might reduce their activity. If they have kids to look after, all of these sorts of things, real life kind of gets in the way of our, the things that we think we just write a little prescription and walk out of the room. It's just ridiculous, these folks. So again, doing things with them is the way forward. But if we look at the data, and these are data from our unit and other units around the world, and about 20 years ago, we did some studies, and this has been repeated now in studies since. We found that folks, when we gave them a good quality offloading boot that was removable, they only wore that removable device for about, give or take, 28% of their total activity that they took every day. So about 3/4 of their activity that they took was with the device off, right? And you're not going to get very good results writ large if 75% of your dose of any drug that you were given, in this case it's offloading, is not being taken. And so how can you remedy that? And what we have found is that making that irremovable device, if it's a boot, making it removable by wrapping it with a layer of Coban or plaster, or putting someone into a cast, which of course has been the gold standard. And what we found is that increases healing dramatically, but it is really hard for the patient. And so more recently now, and I think this is kind of where we're going, is we've been trying to work wearables into this to where we are actually giving people information about, hey, this is how adherent you are. This is how maybe non-adherent you are, but why is this? Why are you not doing this? Maybe we can, work on that together. And again, doing something with them and not to them.
That's awesome. And you kind of started speaking towards my next question of adherence. So, you mentioned that this can be um, difficult for a patient to work into their daily life. So how can healthcare providers encourage adherence to these treatments? You started talking about it, about what you can do, but if you had to give your fellow colleagues, this is something we tried, or are there like a couple things that you're like, this might help encourage adherence to these offloading treatments among patients?
Yeah, that's a great question. So I think just giving them as much or as little, every patient is a little different. I don't need to tell my colleagues about that every patient is different, but I think you gotta meet them where they are, especially for this problem, because again, this does not hurt them, generally speaking. And so it is going to rapidly, when they leave that room, because it's not symptomatic, even though it's a wide open wound, and your medical student, the nurse, the doc, others in the room, they will have more of a visceral reaction to that wound than your patient will, which sounds crazy because it's a wide open wound. But you just have to understand that. And this will rapidly become 11th on our patient's 10 most important things the moment that they step up and walk out the room. So how do we bump it up to maybe, I don't know, humbly, maybe we can make it 9th on their 10 most important thing? Well, just you have to keep at it. And you have to say, Ms. Jones, Mr. Rodriguez, this is the problem that you have, and this is why you need to do this. And you have to just keep on, as the politicians say, keep on message talking to them, because just because you said it doesn't mean they heard it, and doesn't mean they're listening. And sometimes you could say it 10 times, and the 11th time maybe they hear it, and or you think so. You think you've done it so many ways, but they got so much going on in their lives. Come on, how can we blame them? So doing it with them again and not to them. I think I've said that each and every time is the way forward. And if we give them, like the guy I just saw, he loved watching these pictures because he loved seeing the results. And a lot of people want a number, just like they might want to know their A1C, right? And others might not want to know that. What they might want to know is, oh, doc, you do everything. Just take care of it. I just want to be done with it. And so everyone is a little bit different, and you have to dose the adherence by making something irremovable or making it, removable. And the type of device these are the kinds of things that we work on each and every day. And again, it's super easy, Jakara, to talk about on a Zoom call, and it is harder to do in real life, but it is frustrating. And I will say, looking at my clinic right now, pretty rewarding.
That's awesome. Well, I have two more questions if I can and bother you with that. And you started talking about it a little bit when we talked about what does this look like moving forward? How do you evolve the field of offloading? So how do you anticipate the offloading techniques evolving in the future? What future trends do you see? What do you see there?
Yeah, so it's actually a fun time in this area. And I mean, you wouldn't think, I mean, just boots and the casts and things, but what's really cool now, finally, is we've been merging kind of next gen technology and next gen design with these. And we have a really great study that's funded by NIDDK, the National Institute of Diabetes and Digestive and Kidney Diseases. That's a mouthful. I need to buy a vowel in that NIDDK, I think, another I or something, maybe. But my friends and colleagues there have funded what we call the Smart Boot study. It's a big study now. We are, I think, 148 of 210 patients enrolled now in this study as of today. Yeah, it's great. And we are randomizing people into boots that people will want to wear. This is a device that was designed, believe it or not, by this guy, Mike DiTullo, who designed the second and third generation Air Jordans. So they're boots that, these offloading boots that normally look really big. And this is still a below the knee device, but it looked cooler. And also patients want to wear it. And we are giving people wearables on the device and on a smartwatch, and we're able to see when the patient is wearing it and when they aren't. And so we could say, hey, you've been wearing this device, 75% of your total activity during the day. That's pretty good. Let's see if we can get up to 80 or 90. And we're now working on new ways to kind of prompt them to do that. And everyone's a little bit different there. And then on the and then on the other end, oh no, Ms. Garcia, that boot looks like it's sitting next to your couch, or it's acting like a doorstop in your house instead of acting, like a device on your body. What can we do about that? And so this kind of thing is happening, now, and I liken it to a lot of the work that was done early on in glucose monitoring, now to where we can counsel folks on this and almost dose activity and adherence, just like we might dose their insulin.
That's awesome. It seems like the role of technology and also providing that real-time information is allowing you to meet patients a little more where they are, get more real-time information, and that will help them and help your staff as you counsel them through their diagnosis. That
for
sounds
sure.
amazing.
For sure.
So my last question here is, do you have any resources or things or reports or anything off the top of your head that you think may be for folks to just check out if they want to learn more about offloading and these techniques?
Oh, listen, you'll need a digital restraining order after you talk to us on this. So you guys can have as much or as little as you want, but maybe what we can offer, Jakara, in the show notes or online, or just maybe a link, we can give you a link to our international working group on the diabetic foot on offloading. We have a bunch of other things. I can even send you over to our smart boot study. Gosh, if you're in the LA area, you guys are so welcome. We can get people free boots and get them into something, but there's just so much going on right now. And it really is an exciting time now to where we can help folks move through the world a little bit better and get them healed, get them into remission. And then we would say maximize their ulcer-free days, their hospital-free days, and their activity-rich days. How's that sound for a trifecta?
That sounds awesome. Well, thank you so much for taking the time to talk to us today. Really learned a lot, and we'll make sure to link any of these resources that you said. We'll make sure to get that to our audience as well. But really do appreciate you taking the time with us, Dr. Armstrong.
Grace, you are the best. Thanks a million.
Well, thank you so much.